Right. Well, why don't we'll go ahead and get started then, since we're passing the turn of the hour. So, yeah, hi everyone. Thank you for joining. Welcome to another week of our grand rounds in the Department of Psychiatry and Behavioral Sciences. I am really excited about this session today and our speakers, so I will go ahead and introduce and then hand to him. So we're fortunate to have Dr. Gregg Robbins-Welty joining us today. He is an assistant professor of hospice and palliative medicine, general internal medicine, and medical psychiatry at Emory University School of Medicine. He is board certified in internal medicine, psychiatry, and hospice and palliative medicine. And he is certified as a healthcare ethics consultant by the American Society for Bioethics and Humanities. He completed combined training and chief residency in internal medicine and psychiatry, as well as a fellowship in clinical ethics at Duke University. And Dr. Robbins-Welty obtained his medical doctorate and a master's in clinical research at the University of Pittsburgh, where he also completed his clinical fellowship in hospice and palliative medicine. At Emory University, Dr. Robbins-Welty splits his time as a clinician researcher, clinically serving patients at Grady Hospital, rounding as a palliative medicine consultant, as well as an attending physician on the medicine psychiatry unit, and researching the interface of medical ethics, mental health, and palliative medicine, on which he has written and published extensively. He is an awardee of numerous awards, including fellowships from the American College of Psychiatrists, the Academy of Consultation-Liaison Psychiatry, and the American Psychiatric Association. He is the awardee of the Martin Fenton National Resident of the Year Award from his Association of Medicine and from the Association of Medicine and Psychiatry. And in his spare time, Dr. Robbins-Welty performs and records bluegrass music with his 2019 album, Gregg Welty Community, having been named a top bluegrass album of the year. Very cool. All right. Well, Dr. Robbins-Welty, thank you again for joining us. I will turn it over to you.
That was an incredibly kind introduction and bio. I'm so grateful and really excited to be here. Can you all see my slides? Can you see my title slide?
Yes.
Um, yeah, I just want to start by saying thank you so much for the opportunity to be here. In my sort of bluegrass life that you alluded to, I've actually spent some time in New Mexico. There's actually a pretty robust bluegrass music community where you all are, and so it's just sort of a fun fact. So it's really fun to be here with you all today. I'm going to be giving you all a talk called "Shocking Comfort: Should Anyone Die Without a Trial of Palliative ECT?" And my hope today is that we can learn a little bit about what that is, what that means, and also maybe an answer to that question, but maybe not. Um, I just wanted to start again with a thank you to you all for being here and also for the opportunity to talk with you all. This is one of my favorite pictures of my research team and I doing some of the data analysis that I'm going to be presenting to you today. Look how happy we are to be working together. And also just a thank you to some of the institutions that I have had the opportunity to work at, and Duke specifically, where some of this data comes from. And I'm going to be sharing with you all today, of course, Emory, where I work now, and Pittsburgh, where I did some of my training. You know, when I was in training, I was a student and then a resident, and then a fellow. I always found it really helpful when the grand round speakers would come and give a little bit of their personal history and why they became who they are and why they study the things that they study. And before I get to that, I just want to disclose that I do serve as an associate editor for the Journal of Palliative Medicine, and I get a very modest amount of money to do that. That's kind of irrelevant to my talk today, but just sharing a disclosure. But I share this picture, A, because that's me there in the middle. And if you can't tell, the eyebrows are the dead giveaway. Um, but I share this picture of my grandparents because this is really the inspiration for all of the work that I do, and really the driver for what really my passion and my career, and what I've been trying to study. My grandmother, who you see here, suffered her whole life from a pretty severe bipolar disorder. And I grew up in a small town where medical care wasn't necessarily the most robust. The closest hospital was 45 minutes away. And she got a community-acquired pneumonia, a very treatable condition. And she suffered likely delirious mania as a consequence of her pneumonia. And when she arrived at the local hospital, they triaged her to the psychiatric unit instead of to the medical unit, and she died pretty unexpectedly and suddenly. And it was a pretty tragic experience for me and my family. My grandfather, who you see pictured here, subsequently was diagnosed with pancreatic cancer 4 days later. And he moved into our home, and we had hospice services, and he actually had a very dignified end of life experience. And not only has that really been a motivator for me to really study this interplay between medicine and psychiatry, but also end of life care my whole life. But I'll tell you an anecdote that my mother quit her job as a flight attendant and went back to school and became a nurse, and she ultimately became a hospice nurse. And so I've really been on this path ever since I was quite young, perhaps not as young as this picture, but I share this because really I've spent my career thus far and plan to continue to do so, obviously putting the patient in the middle, but trying to study and examine the overlapping spaces between internal medicine and hospice and end of life care, palliative care, clinical psychiatry, and then really medical ethics. And if we zoom in a little bit to this overlap, where we're going to be talking a lot about today is this overlapping space between clinical palliative medicine and clinical psychiatry. And maybe you're asking the question, what do we call that overlapping space between palliative care and psychiatry? Is it palliative psychiatry or is it palliative care psychiatry? Is there even a name for this thing? And maybe you're wondering, I wasn't thinking actually at all about how you label this thing. Maybe I'm wondering, why would you even need to do that? Is that even an entity that we would need to study or think about at all? And I would argue that it is. There are a lot of reasons why we ought to consider the combination between palliative care and psychiatry, or at least that overlapping space. First of all, psychiatrists or psych-trained folks or that work in the mental health discipline, broadly, it does not need to be physicians, as well as clinicians that work in the palliative care space. There are profound silos in both of those trainings, clinical practice, as well as the research infrastructure and publication settings that hinders integration of these two specialties. But it's impactful. In fact, half of patients, 50% of those patients who receive palliative care have depression or anxiety that meets the threshold for clinical impact and has real impact on the patients. And it might surprise you to learn that 90% of patients die with delirium. And the presence and magnitude of these psychiatric comorbidities actually impacts the patient's quality of life. That might not surprise you. But there's been studies after studies after studies that show that it's related to impairment in function, higher physical symptom burdens. So the symptoms that the palliative care clinicians may be managing, pain, shortness of breath, nausea, all of these things are worse if the mental health symptoms are unmanaged. And then there's differential healthcare utilization, where patients earlier in the course of their serious illnesses, their serious palliative care eligible diseases, they receive less healthcare than they ought to. And at the end of life, they actually receive more healthcare that is perhaps non-beneficial. And when you look at patients with serious mental illnesses, serious bipolar disorder, schizophrenia, et cetera, they have particular disparities. And in fact, patients with serious mental illness die between 10 and 30 years prematurely, and they're less likely to receive medical care that's appropriate or timely at all. And patients under psychiatric care, commonly, the reverse is also true, that they often have serious medical illnesses, which could potentially benefit from palliative care. So going back to the question, do we call this palliative psychiatry? Do we call this palliative care psychiatry? I thought I would give you all a definition so that we could all be using the same terms. So the widely accepted term palliative psychiatry is more of a philosophical framework where we think about the way that a palliative care clinician might think about medical problems that are life-limiting or perhaps have a poor prognosis, and use that framework to apply to serious mental illnesses. And this isn't necessarily what I'm going to be talking much about today, but just so we're all on the same page, palliative psychiatry is mental health care that centers quality of life of patients and their families. And especially those serious mental illnesses that are likely to result in significant morbidity and or mortality. And really what it asks is, do the burdens of our interventions outweigh the burdens imposed by psychiatric symptoms? And so it aims to respond to that question by responding to the suffering of individuals experiencing serious mental illness and reduce their risk of aggressive treatments by focusing instead on their quality of life, while also emphasizing the necessity of psychiatric symptom reduction. Now, this is controversial and really difficult to actualize. First of all, it makes that assumption that the interventions that we use perhaps institutionalization, forced treatments, trying multiple lines of psychiatric treatments without seeing perhaps much benefit, it makes the assumption that those interventions impose more burden than the psychiatric symptoms themselves, which may or may not be true. Secondly, it's difficult to define what is a palliative intervention in psychiatric healthcare or mental health care. And we're going to talk a lot about that question today. Furthermore, I'm not sure the last time that any of us have seen a patient who's coming to us for a cure. In mental health care, we don't generally offer cures. And so, given that there aren't necessarily curative intent psychiatric treatments, we already focus on quality of life in the here and now. And so, how is this healthcare any different than normal psychiatric care? There's also no operationalized means to identify for which patients would be most appropriate for this. And then, of course, the challenge of prognostication in mental health adds an extra layer of complexity here. You don't know who will get better and who will not get better. And then lastly, when we're focusing on quality of life, who decides who has good, fair, or not good or not fair quality of life? Is it the clinician or is it the patient? And when we're dealing with serious mental illness, you get into ethical complexity very soon. So I want to take that palliative psychiatry idea and set it aside for a second and shift gears to leaning into what's called palliative care psychiatry, which is the clinical domain, really developing subspecialty at the interface of clinical palliative medicine and psychiatry. Wanted to share with you this article, which I was really grateful to be a part of, and with many of experts in the field, that outlines exactly this: that what are the growth edges, what are we currently doing, and what we might be doing, what should we be doing in the future at this interface between palliative care and psychiatry. And one of my favorite figures from this study is shown here on the screen. And essentially what we have here is we have the setting at the top. So you can see on the left-hand side, we've got medical settings, and on the right-hand side, we have psychiatric settings. And down the left-hand column, you can see the different aspects of clinical care in this overlapping space between palliative care and psychiatry. So for example, if you were a psychiatrist, like the folks that you all are training, what training might you get if you wish to practice in palliative care psychiatry, depending on the setting you were in? So if you were in a medical setting, perhaps you would do a psychiatry residency and then followed by a hospice and palliative medicine fellowship. There's a growing number of folks that do that. If you wanted to be in a psychiatric setting but really work in this space, perhaps you would do general psychiatric training, or perhaps if you wanted to be in an integrated space, you would do CL fellowship. There's other points to be made here on this screen, for example, educational interventions or what patients you would actually be treating. Now, when I think about this, and I just want to be explicit that this is how I think about this, I think the takeaway is that there are lessons to be learned in psychiatry that we can learn from clinical palliative medicine, and vice versa. There are plenty of lessons that palliative medicine can learn from psychiatry that they've got figured out. And so I want to share with you some ideas, and just to be explicit, this is not to say that we don't already do this in psychiatry, but these are the things that palliative care does well and is really built into the DNA of the specialty. Things like deprescribing, goals of care conversations, making sure that the decisions that we are doing are values aligned and make clinical sense based on the prognosis and who that patient is as a person. Promotion of values-based decision making, caregiver support, reliance on an interdisciplinary team, as well as these sort of ethical explorations of concepts such as palliative psychiatry. The opposite is true as well, though, that palliative care can learn a lot from us in psychiatry. For example, knowledge and use of psychotherapeutic interventions. There's a really growing field of folks who are using things like psychodynamic psychotherapy to help with existential distress at the end of life, for example. There's standardization of terminology and descriptors. We could criticize perhaps the Diagnostic and Statistical Manual of Mental Disorders all day long, but at the same time, it gives us a great framework. And when one clinician and another clinician see the same patient, they know at least that they're talking about the same thing. Palliative care, as well as psycho-oncology, has really been plagued by using terms that aren't necessarily well standardized, like demoralization, for example. And so I think we can use some of the things that we've figured out in clinical psychiatry and palliative care. Advanced psychopharmacology, I think that one sort of explains itself. And really, as a transition to talking about what we're going to be talking about today, what about interventional psychiatry? And so when we think about interventional psychiatry, we think about one of our oldest treatments in mental health care, and we think about electroconvulsive therapy. And my headline here is that ECT is a really effective treatment. It works really well. It's very safe, it's very effective, and we use it all the time for things like severe mood disorders, psychosis, catatonia. And why I think it's particularly relevant and interesting and something that I think we should be talking about more in the palliative care world is that we use it when treatments don't get better with other treatments. When the treatment is refractory, we go to ECT. The other thing that I think is really important to think about is this is the treatment that we would use when time is short. This is not only the most effective treatment that we have for these conditions, but it's also the fastest treatment that we have. And so if you had a condition where your time was short, perhaps you ought to be thinking about using something like ECT. And given that treating psychiatric illnesses aligns with palliative care philosophy, when might we consider doing something like palliative ECT? And so this is my segue here, where the first thing that we need to do is think about palliative ECT as a concept. Because you can imagine that palliative ECT has been understudied and it's also been very vaguely defined. And I want to offer to you all four different potential definitions of palliative ECT that are based on different understandings of the word palliative. So first of all, to palliate is simply to relieve symptoms. And so by that logic, when you use ECT to relieve symptoms, you are relieving symptoms of depression or catatonia or psychosis. It's a little bit difficult to determine how normal ECT that relieves symptoms would be different from palliative ECT. And certainly this broad definition of just saying, well, it's palliative because it relieves symptoms doesn't necessarily hit upon the ethical challenges and really what we're trying to get at here. So perhaps it's palliative just purely by proximity to serious illness. If we're doing ECT for patients who have a life-limiting diagnosis, perhaps a cancer diagnosis, maybe it's palliative just by setting. It's palliative because we're doing it in a palliative care context. Perhaps it could be something else, though. Perhaps it's palliative care or palliative ECT by delivery. And I think a helpful way to think about this is palliative dialysis. So dialysis is typically for its full life-prolonging benefit is given 3 days a week. It's usually a 2 to 3 hour treatment. But there's such thing as palliative dialysis where they actually manipulate the amount of time or the number of times the patient goes per week to try and meet the patients where they're at, acknowledging that there are trade-offs in its life-prolonging benefit. So perhaps you would do dialysis twice a week for an hour, something like that. Perhaps that's what we mean by palliative ECT. Maybe we change the way we think about the index course or how many treatments we're doing or the medications that we're giving. We haven't really studied that ever, but perhaps that's a way to think about palliative ECT. And then the last way that I could imagine us talking about palliative ECT is palliative ECT by way of intent. And what I mean by that is generally when we're giving ECT or really any psychiatric treatment, our intent is to relieve the psychiatric symptoms all the way off, all the way gone. We want symptoms to be zero. And there might be cases in which we don't expect psychiatric symptoms to completely resolve. And so by that context, you might think about palliative ECT in the same way that you think about palliative chemotherapy, where we're treating the cancer, but we don't expect to actually cure the cancer. We're hoping for more time. We're hoping for improvement in symptoms. We're hoping for improvement in function, but we're not expecting complete resolution of the symptoms. And so these are all different ways that we could think about and define palliative ECT. And my headline for you is that this has not been well defined, and that really any of these might be the way that we think about palliative ECT. And so what can we do? We can go to the literature and see what has been written about palliative ECT in the past. And the answer is there's been 3 case reports. So there's, pretty robust literature base behind this work. And I want to share with you that among those 3 case reports, most of them were essentially using ECT for chronic psychiatric conditions in patients in a palliative care context. So, for example, a patient with a terminal cancer who then received ECT. And most of the case reports that have been published were continuation of ECT that the patient was already getting. For example, a maintenance course of ECT. Now, there was one case, which is sort of interesting, where they administered a new ECT index course, and it provided a patient with metastatic pancreatic cancer and his family rapid and significant improvement in his quality of life and his ability to communicate in the days before his death. And so you might wonder, okay, that makes sense. Just because the patient has cancer doesn't mean we shouldn't be treating his mental health symptoms. That's great. But the question is, why aren't we doing this more often? Or why is there not a robust literature base behind this? And I would argue, this is again me saying this and not based on literature, but I think stigma, and more stigma. The One Flew Over the Cuckoo's Nest really did a number on perceptions of our interventions. It's a hard business being an ECT doctor. There's also access issues, legal restrictions. For example, if you are at the end of your life because of cancer, for example, and you aren't able to consent for the procedure, but yet you still are appearing catatonic, for example, if you can't consent for ECT, you might not be able to get it depending on where you live. Having lived in 3 different states for my training and my junior attending faculty position, the ECT laws are dramatically different depending on where you live. I think another reasonable reason to think about barriers would be concerns about the procedural risks in medically fragile patients. Patients with advanced cancers, for example, are generally quite medically frail or fragile. So you might worry about the aggressiveness or even the safety of doing something like ECT. And of course, then there's also the logistical concerns related to the frequency of treatments. If you're doing a new index course, the patient has to go to the ECT suite 3 times a week. And is that inherently detrimental to their quality of life? And then lastly, there's just no data. There's really nothing out there to help us guide these really challenging clinical decisions. And so this is what I sought out to do over the last few years. And so I'm excited to share with you some of this data and describe to you this study that's named Palliative ECT, a descriptive cohort study that was published last fall in the Journal of Consultation-Liaison Psychiatry. This was a single site retrospective descriptive cohort study of patients with serious illness, which we defined as patients having had received a palliative care consultation and or were in receipt of a do not resuscitate code status that were evaluated for ECT in either the inpatient or outpatient setting over a 5-year time period. And our data sources were pretty broad. And again, you can see this picture is, again, camaraderie and teamwork at its finest in this picture. The data sources were broad. We looked at the ECT notes, we looked at the palliative care notes, we looked at the discharge summaries, the progress notes, the H&Ps, the ECT administration records, all of the flow sheets, and we developed an a priori structured review form to make sure that all of our data that was extracted was consistent across reviewers. And we essentially gathered every single piece of data that we possibly could think of to gather. And that included things like demographics, medical and psychiatric history, advanced care planning, code statuses, ECT history, the Bush-Francis scores, the Montreal Cognitive Assessment, measures of cognitive function. We also did a qualitative assessment of the charts. We really wanted to get a sense of what happened to these patients, what were the decisions that were being made, how did the patients, their surrogates, and also their care team make the clinical decisions that they were making. We wanted to look for outcomes, of course, and we also wanted to look for evidence of clinical improvement or not. So we looked for things like oral hydration and intake, activities of daily life performance, quality of life metrics. It might surprise you to learn that ECT consult notes don't generally have standardized forms for quality of life assessment. So we tried to look for markers of that, things like evidence of enhanced communication, time out of the hospital that would have otherwise been spent in the hospital. We also looked for evidence of decreased mortality. I need to be explicit that we didn't do standardized mortality metrics, but we looked for things like patients who were in the ICU ultimately got ECT and then were no longer in the ICU and had reversal of their weight loss, things that were sort of metrics and markers of decreased mortality, potential decreased mortality. We also looked for the reasons that palliative care was consulted and also why ECT was consulted or considered, and were those two things related? We also looked for reasons why ECT was pursued or not, if there were any complications, logistics involved in the ECT and legal consent process, changes in the diagnosis throughout the medical course, and then as well as going back to this idea of intent, we were kind of wondering if the clinicians actually documented in their reasoning they were pursuing ECT either with curative or palliative intent. We sort of explored that as well. So I'm excited to share with you some of our results. So to start with, there were 31 patients that had been evaluated for ECT and also had a palliative care consult or a do not resuscitate code status order. 21 of those patients ultimately received ECT and 10 did not. They were of similar ages and in roughly their 6th decade of life. Most of the patients were female and most of the patients were white. Looking at their psychiatric diagnoses, the vast majority of our patients were being treated or evaluated for ECT due to a major depressive diagnosis. A quarter or so had bipolar disorder, and another quarter had a psychotic disorder of some kind. And the indication for ECT ultimately was catatonia in 2/3 of cases, but it was treatment-resistant depression in about a quarter of cases. It's important to note that no patients were referred to ECT for mania or psychosis without catatonia. And so if a patient had depression and catatonia, we would say that was catatonia, or psychosis and catatonia, we would say that was catatonia, even if it was due to different underlying disease states. Looking at how the patients were actually broken up, 19 of the patients, or about 2/3, had a do not resuscitate code status, and another 20 had received palliative care consultations. 60% of the palliative care consults that were actually put in were related to the patient's psychiatric illness. And looking at that more granularly, 4 of the consults were about goals of care, specifically regarding whether or not pursuing ECT would be values aligned. 5 of the consults were in regards to feeding tube placements in the setting of catatonia and whether using artificial hydration and nutrition was values aligned. And 3 of the consults, interestingly, were actually in the setting of advanced care planning in the setting of treatment refractory mental illness, which I think was kind of interesting. Moving on, thinking about medical comorbidity among this seriously ill population, 1/5 of our patients had cancer, 1/4 had end organ disease, which we defined as things like advanced heart failure, advanced COPD, advanced renal disease. Another 1/4 had a major neurocognitive disorder at pretty advanced dementia, and 13% had failure to thrive of sort of an unknown etiology. While the medical comorbidity was quite high, it certainly affected the ECT physician's evaluation, but it did not preclude our ability to provide ECT in 30% of the patients. And so that included patients, one who had aortic stenosis that was quite severe, so severe actually that they were admitted to the intensive care unit for the ECT administration, and the ECT was done in the ICU, a recent stroke and a subdural hemorrhage, another patient with stress-induced cardiomyopathy. All of these patients, the ECT clinicians thought hard about whether ECT was safe and indicated, and ultimately went forward. And in 3 cases, medical comorbidity was too profound to safely proceed with ECT. That included 2 cases of pulmonary hypertension that was quite severe, and 1 case of severe hypertrophic cardiomyopathy. For the ECT nerds, and by that I mean experts, 21% or 21 patients received ECT, as I've mentioned before. Our mean index course was nearly 15 treatments. The mean energy was 95.5. Most of our patients received 1 millisecond pulse width, and 12 of the patients ultimately received maintenance courses of ECT with a mean of 26 treatments. You can see here 1 patient actually received 112 maintenance treatments of ECT. When we think about the patients that received ECT, we looked more granularly at some of the decisions that were made during those patients' disease courses. And so one thing to know is nearly, I guess, 75% or so had a surrogate decision maker who consented for ECT, which is not actually feasible in some places. Patients consented themselves, much less commonly. That was in 4 cases. And in North Carolina, we had 2 physician consent for ECT, which has not been something that I had available in anywhere else that I've worked or lived. And that was done in 1 case. And when we look at some more of the outcomes of patients who received ECT, every single one of them experienced some degree of psychiatric symptom reduction. And some of the evidence of that improvement included improved communication in 15 cases, improved nutrition, hydration, and oral intake in 14 cases, functional independence in their activities of daily living in 12 cases. Among those patients who received ECT specifically for catatonia, the mean improvement in the Bush-Francis catatonia rating scale was 17, which is pretty dramatic. And among those who received ECT with palliative intent, meaning the physicians did not think that the patient would actually functionally medically improve, even among those patients, they demonstrated improvement in their quality of life, even at the end of life. And to underscore one of these points, the ECT in our cohort was associated with reversal of life-threatening weight loss for 1/5 of our sample, which we thought was pretty dramatic. When we're thinking about some of the complications, they were relatively rare. We had a case of aspiration pneumonia, a case of periprocedural bradycardia, but they weren't associated with patient fatality. The patients themselves had other serious illnesses, things like cancer and advanced medical illnesses. And so many of the patients had passed away by the time we had done this retrospective evaluation. And so about half of the patients had passed on. 8 of them had received ECT, and 6 of them had not. When we're looking a little bit closer at some of the cognitive function data, 13 of these patients carried a major neurocognitive disorder diagnosis, but among those who received ECT, 5 of them actually had complete restoration of their cognitive function, and therefore their diagnosis had been changed from major neurocognitive disorder to either psychotic depression or catatonia. And even in those who maintained their major neurocognitive disorder diagnosis, 8 of them still experienced improvement in their cognition, though still met criteria for major neurocognitive disorder after that. And the mean improvement in the MoCA, the Montreal Cognitive Assessment, was 5 points and ranged between 0 and 17. What about those patients who did not receive ECT? Most of them didn't receive ECT essentially because there wasn't an indication. And this included patient, for example, who had a really severe TBI and another patient who had a severe hypoglycemic coma. Both of these things, the question was, is this catatonia and ought we proceed with ECT? And it was felt like this was unlikely to be catatonia. Instead, it was a persistent vegetative state or something that looks similar. And then in other cases, the medical decision makers, the surrogates, decided against ECT in 2 of the cases after having goals of care conversations with palliative care. Both of those cases were patients of catatonia that were in the ICU. One had had ECT in the past and had already provided a psychiatric advance directive and spoken with their families about not wanting to proceed with that again if they ever found themselves in that situation. And the other one was a particular high-risk case of pulmonary hypertension. So when I summarize all of these results and lean in a little bit to what we have here, this is the first cohort study that really explores palliative ECT as a concept and examines 31 patients who received or were considered for palliative ECT. All of the patients received ECT. All the patients that received ECT did so for either catatonia or treatment-resistant depression. I think this work pretty dramatically affirms decades of safety data that we have that shows that ECT is really effective, it really works, and it's also quite safe even for patients who are medically complex. And so all of our patients who received ECT exhibited improvement in their symptoms and or functional status. They had improved quality of life, at least based on our metrics and markers that we had. Complications were rare and not associated with mortality, and this aligns well with the existing palliative ECT case reports, but also decades of safety data that says that ECT is a safe and effective treatment. I think it does raise these questions about using our psychiatric interventions like ECT. Can it be a palliative intervention? Could ECT be included among the continuation of other palliative, symptom-relieving yet life-prolonging interventions, things like palliative ECT or palliative dialysis or palliative transfusions? And I think it raises the question and doesn't necessarily answer it. The thought and the risk-benefit calculus that needs to go into these decisions. I mean, one might argue that these patients did really well despite doing, besides being quite clinically sick and 50% of the patients dying. But on the other hand, it doesn't answer the question why clinicians might be hesitant, things like hospital visits, anesthesia, procedural risks. I think it does share that 90% of our sample were patients with serious illness and otherwise would be eligible for receiving palliative care, or perhaps even hospice care. And a third experienced mortality during our study. But no less, these things require thoughtful risk-benefit analysis, which also requires data. And this is really just the tip of the iceberg in that domain. I think it's important to point out that ECT reduced mortality for nearly a fifth of our sample. And I think that that underscores these points that psychiatric illnesses pose substantial risks for morbidity and mortality, which are things that we don't necessarily talk about in our day-to-day practice. And I think that's underscored by the fact that nearly half of these patients were even referred to folks like me in palliative medicine because of their psychiatric illness. The other important point that I think is I really want to emphasize here is the confusion of catatonia for major neurocognitive disorder. And this was a really unexpected finding in our cohort. Nearly a quarter of the patients in our sample had been misdiagnosed as having a dementia diagnosis. And what I'd like to just spell out for what we saw in the charts was essentially it was a common phenomenon for palliative care to be consulted for a patient with rapidly progressive dementia for whether or not artificial nutrition and hydration would be aligned with goals of care. And if you were to make the assumption that this is a major neurocognitive disorder and therefore irreversible, foregoing life-sustaining treatments might be very reasonable. But ultimately, what happened is the patients got an ECT consult. It turns out it was actually psychotic depression or catatonia, and the patients walked out of the hospital. So I think it does raise this question about how do we make our diagnoses when we are making observational diagnoses? How do we make sure that clinicians outside of our expertise in clinical psychiatry familiar with our diagnoses like catatonia, for example, that can be life-threatening? And then it asks these questions, how do we guide medical decision makers and surrogates through these really difficult choices when we're kind of unsure if the patient will get better with something like ECT? Do we say things like, well, it's worth a try? I mean, there's risks associated with doing this intervention. Or do we forego these life-sustaining treatments because of our hunch that this might be a major neurocognitive disorder versus catatonia? I think the last challenge there is even among the patients that they did, in fact, have a major neurocognitive disorder, they still had improvement in their MoCAs when they got ECT, even if it didn't improve all the way. And so perhaps there's a role for ECT in dementia care more so than that has been previously appreciated. And I think it raises this question. There's a lot of limitations for us to go through with this study. Of course, first, while it is the largest study of palliative ECT to date, it's a small sample size. Inclusion criteria, all patients that received a palliative consult or had a DNR does not necessarily mean all patients with serious illnesses, and it could be prone to bias and be non-representative. This is a retrospective, non-randomized design. It's limited by the availability of documentation and data in the chart. And there's also limitations here because this was all drawn from a single institution where culturally ECT is done commonly with a low threshold. We have the ability to do things like ECT in the ICU, for example, which may or may not be legally, institutionally replicable elsewhere. And I think that that's a major limitation. I think there are some conclusions that I can certainly say as a result of this study. First of all, I think palliative ECT can reduce patient suffering and improve quality of life. I think in our sample, we saw diagnostic clarity. It was observed with the use of ECT for patients with cognitive impairment and failure to thrive that we thought was advanced dementia. I think ECT can be given with palliative intent, even if you don't think that the patient will get all the way better, either psychiatrically or in the setting of a medical illness that is unlikely to get better. And I think that there's an opportunity here for palliative care clinicians as well as psychiatric clinicians to collaborate and consider the full range of treatments to make sure that we're managing suffering, especially with patients with serious medical illnesses and especially at the end of life. Now, while I think I can say all of these things definitively, I do think that there are some questions that I can't necessarily answer based on this data, and I hope that these are thought-provoking questions. One is there a role for ECT as a diagnostic tool in the setting of cognitive impairment or failure to thrive? Is ECT not just a treatment, but is it a test? Is there such thing as, instead of an Ativan challenge for catatonia, is there such thing as an ECT challenge? It's a question. How do we contextualize this whole concept within that greater palliative psychiatry ethical philosophical framework that I probed at the beginning? When do we recommend comfort-focused end-of-life care versus something like ECT when we're uncertain about what is going on, when we have diagnostic uncertainty? And then lastly, should anyone die without a trial of palliative ECT? And so with that, I am so grateful, and I'm really excited to answer questions. And if you would be so kind, this would be very helpful if you wouldn't mind filling out a survey and give some feedback, because I would be honored to learn from you all and receive your feedback and continue to improve this work as well as this talk. And again, I'm so grateful for the opportunity to talk with you all and excited to answer questions.
Cool. Thank you so much. Thank you, Dr. Robbins-Welty, for the education and for the presentation. I see there's one question in the chat, and then of course if folks want to unmute, but it looks like we have a question about worry about ECT in folks with transdermal medications, especially in individuals in the cancer population.
I think that's an interesting question. Fentanyl patches don't necessarily give you as high of a dose of opiates as you might think that they do. The oral morphine equivalence of something like the highest dose of a fentanyl patch is actually not as high as you might think that it is. And it's certainly not as high as what an anesthesiologist is going to use to induce general anesthesia. So I think you can be thoughtful about, okay, what's the equivalent dose of opiates this patient is getting through the patch, and then the anesthesiologist can be thoughtful to not overdose them on opiates during the induction process of anesthesia. I haven't actually seen this be a major issue or come up. And in fact, using something like a patch, which has such a gradual on and off, might be helpful to make sure that the patients aren't getting boluses of things like sedatives and opiates during induction of ECT. And then it can actually help them make sure that their pain is still well managed, like their cancer pain, longitudinally. I don't know that ECT would really impact that. Um, but it's a really thoughtful and interesting question.
Thank you. Yeah, other folks have questions or want to unmute at all?
We've got some exciting results with switch from major neurocognitive disorder to psychotic depression catatonia with some recovery. I agree. I think it was striking to find, and one anecdote I'll share is, I did this work during my chief year, and then I went on to do palliative care fellowship. And one of the very first patients I ever saw in palliative care fellowship was a patient that was advanced, rapidly progressive major neurocognitive disorder. And I walk in the room, and it's the most floridly catatonic patient I've ever seen in my career. And when I told my attending when I was a fellow, I think this is catatonia. I think we need to get some Ativan and some ECT in here. They looked at me like I had three eyes, and so I do think that there needs to be a culture shift um, to consider these as diagnoses that are recoverable. Because of course, if the patient has advanced dementia, it doesn't make sense to be putting them through aggressive interventions. However, how confident are we that it wouldn't actually help even if it is advanced dementia and or that it's not something else that's reversible like catatonia? I think it raises all these interesting questions. And
I might actually ask one question if that's okay about in terms of like training and I think we have residents who have come through and had um, a lot of interest in palliative care, palliative medicine, and not quite been sure about like best routes to take if they're interested. We have a palliative care team, and we have a very robust CL service. But yeah, I just was curious if you might have any wisdom to share. I know you did a combined training, of course, with internal medicine, but any thoughts for learners in the psychiatry realm?
yeah, absolutely. I would share, first of all, that palliative care fellowships love psychiatry trained folks. Um, I, I, I know of many. There's a cohort of maybe 75 folks in the country that have done psychiatry residencies followed by palliative care fellowship. And just by way of context, palliative care is a relatively new specialty like consultation-liaison psychiatry. And the American Board of Psychiatry and Neurology was one of the founding sort of sponsoring boards for hospice and palliative medicine. So as a psychiatrist, you used to be able to just grandfather in to hospice and palliative medicine. There's actually a whole bunch of folks that grandfathered in from psychiatry training. But anyway, all of this to say, yes, I did a medicine and psychiatry residency, and I think there is some benefit to having the medicine training. But no less, I think having the psychiatry training actually offers a lot to the internists, palliative care folks that they don't have. And I think that includes things like psychotherapeutics, like all the things we've talked about today, psychotherapy interventions, which is literally 90% of my job every day is sitting with patients and families having a hard time. And I think using psychotherapeutic interventions is really core to that. And I think you would bring that expertise. Um, and then I think the medicine you learn. I think you do a palliative care fellowship in order to learn the skills of prognostication and having these goals of care conversations and learning more medicine in the same way that you would do a consultation liaison psychiatry fellowship. I know a group of folks also that have done psychiatry, CL, and then palliative medicine. So that's also a path. That's a lot of training coming from the guy who did too much training, but no less. It's certainly a path. And then I would suggest if you're interested in this, you don't have to do a palliative care fellowship. There are also ways to get involved in this through consultation liaison psychiatry or in geriatric psychiatry, or there's actually a lot of opportunity to collaborate with palliative medicine and pediatric psychiatry as well. So I think there's a lot of different paths. There was a consultation liaison psychiatrist who rounded with our palliative medicine service in Pittsburgh when I was a fellow. And it was always fun. We got to collaborate on cases, and I would see it more from the palliative lens, and she would see it from the CL lens. though I struggle to, take my different hats off too. But there are a lot of different ways to get involved. The last thing I would suggest is the American Association of Hospice and Palliative Medicine puts on a talk actually every year by the psychiatry special interest group, which is folks like myself who come from psychiatry backgrounds. And we put on a talk for trainees that are interested in considering palliative medicine fellowships. And so look out for that. Join AHPM, come to the conference. There's lots of mental health related and ethics related actually content.
Great. Thank you so much. And yeah, I see we have Dr. Fredericks, also one of our associate program directors for the Palliative Care Fellowship. So thank you for having posted. Yeah, and then Dr. Crawford had a question that's up a little bit about given that needed cultural shift amongst providers, could you speak to the challenges of shared decision making with patient families around this idea?
Yeah, that's a big question. I think, one of the challenges, I guess, to give you a little by way of background, if I were to ask you what your goals of care are with no context, you might say something like, "Well, I'm looking forward to not having to hear this guy talk anymore. I'm looking forward to the weekend. I'm looking forward to finishing my training and looking for." Your goals are abstract and forward facing and based on an understanding that you have time. And if I change the frame and say you've got cancer and you're going to die in a week, your goals change all of a sudden. Now, all of a sudden, it's framed within the prognosis. And this is really palliative care 101. This is goals of care. You can't assess what someone wants in a specific medical context unless you've given the context that they're in and that it fits. And I share all of that to say that the hard part about all of this is that our diagnoses, this is clinical psychiatry challenges 101, that our diagnoses are based on observation. They're not based on labs, they're not based on imaging. We're doing these assessments. And if you never do a Bush-Francis catatonia rating scale, your patient's not going to get diagnosed with catatonia. That's problem number one, is that how accurate are our diagnoses? And if our diagnoses aren't accurate, then how accurate is our prognoses? And then the second question is this, I think, raises real questions. For example, if you need ECT to get better, which I'm sure we've all seen cases of catatonia that only gets better with ECT, it doesn't actually get better with Ativan, then how do you know who will get better and who won't? And then how do you juxtapose that against their medical comorbidities, their frailty? And then how do you weigh all of these complexities when we ourselves struggle to make a recommendation on our own with patients' values? I think one way to think about this, and I've been trying to think about writing this as an editorial or trying to make it a little bit more academic, but one way to think about this is some families are willing to do absolutely anything for more time. You could frame this as a time-limited trial. You could frame it as, let's try ECT and see if it gets better. I want to make sure that you're aware of the risks associated with this, but we can do it and see how it goes. We can pivot and off-road at any time. So you could frame it like a time-limited trial. You could also frame it as what type of family are you? What type of person are you? Are you the type of person who would be willing to undergo intensive interventions for the chance at a little bit more time? Or are you the type of person that going to the hospital at all is already not meeting your minimally acceptable quality of life? And I think that's an easy decision tree uphill. Some families don't want any of this stuff. Sometimes you have the 90-year-old that's frail, that they don't want to be at the hospital anymore at all. And in that case, hospice makes sense. But in a case where it's a person who's like, no, I want to say that I've done absolutely everything, I think that's one tree in the road. But without more data for our diagnoses, our prognoses, and who will get better and who won't, this is where the work needs to be done. I think that's my personal opinion.
Cool. Thank you very much. And then, yeah, Dr. Holguin had a question just about the parameters. Whoops, maybe we lost that. Oh, yeah, the pulse width of less than 0.05 for question about ultra brief pulse width with right unilateral placement.
Yeah. I missed the question too. I was reading all the questions. I think I saw pulse with the left movement. Some patients that undergo ECT, some patients undergo ultra brief pulse. That was a good question. Actually, there was, and this is a good ECT nerd question. So thank you for asking. Yeah, there was a case that we were going to do right unilateral, but it was actually the case that had had a recent stroke, and so they didn't want to do it. There was a lot of complexity here to try and summarize all of the ECT flow sheet data. I don't remember off the top of my head. I might even have some of the slides that has all of the ECT administration specifics. So you can see here, this is like a slide that I have as extras, but there were a number of there was one right unilateral, patient 3, patient 19. There was some bilaterals. There was another right unilateral of 14. So yes, we did. I think it's the headline there. Yes, we did. Um, and so if you are interested in looking at any of this data, this is straight from the supplemental materials of the paper.
Oh, sure. Thank you so much. Sorry, getting a little bit of background. Yeah, I think here at UNM, we haven't particularly utilized the ultra brief pulse width, right, unilateral, but I've sort of wondered in some of these older geriatric patients with like depression, and there may be some underlying kind of baseline cognitive concerns, major neurocognitive versus like pseudo dementia. Um, Whether or not that might be a sort of happy medium, ultra brief pulse width in terms of limiting cognitive side effects versus helping, you know, the underlying depression we're trying to treat. So it's just interesting to see how that practice sort of varies from institution to institution.
I think that's really thoughtful. I am aware of some clinical trials going on right now for using ECT for things like dementia with behavioral disturbance, which is, peripheral, but sort of related to this. And I would be curious to know how they're standardizing that in some of these ongoing trials. I know that there was just a huge NIH funding for a big multi-site trial for that. And I mean, I would love to do some sort of standardized ECT treatment, for patients in the cancer clinic, for example, that are having existential distress or overwhelm or severe depression. We are doing a number of trials here at Emory looking at things like psychedelics and ketamine for those instincts with patients in the palliative care clinic. But I would love to do some more interventional psychiatry things. And I think your question would really need to be answered before you could safely do those sorts of trials is how can we standardize this? Um, and ought we be doing like ultra brief, for example? I think that's a great thought.
Thank you so much. Excellent presentation. Really enjoyed it.
Thank you so much.
Okay. Other questions? I think we've captured most of the chat.
Like y'all have some palliative care folks here, and they're willing to take your residence. That's so great.
For sure. I was going to say, yeah, if people have interest, definitely let's be in touch about making opportunities happen. So cool. All right. Well, Dr. Robbins-Welty, thank you so much again for your time and presence and teaching today. We really appreciate it. And yeah, for the inspiration for us moving forward. So um, yeah, if you have any last thoughts, we welcome them. But again, appreciate your time today.
No, I'm really grateful for the opportunity, and yeah, thank you so much for being here. And hope to see you all down the road sometime soon. And thanks again.
Yeah, thank you. Okay. All right, everyone. Hope you have a great weekend. Take care. Thank you.